Children's Hospital Milk Banks. She's also the Associate Director of the NICU Intestinal Rehab Program and an physician-scientist who is R01-funded. She's studying fatty acid absorption and the liver-gut microbiome access in preterm infants. She's a Dawgs fan, which I just learned, DAWG from Georgia. This recognized expert in neonatal nutrition is going to talk to us about her primary focus, which is the growth and the optimal nutrition and the use of human milk in very low birth weight infants. So I'll give the rest of the time to you, Amy. Thank you so much.
Yeah, thank you so much for the kind introduction, and I'm very excited to be here today. So I have been given the task to talk about enteral nutrition for very low birth weight infants. I love this topic. It could be a whole day conference in and of itself. So I just warn you, we're going to go through a lot of slides, but I hope at the end you'll be able to kind of feel like you have an updated view of the literature. And I will advance my slides here. So yeah, this is where I say that I'm a Georgia Bulldog. So I went to med school in Georgia, College of Med School, and Virginia for pediatrics training, then came to Texas Children's for fellowship. And here I am 16 years later. So I didn't intend to stay, but I thoroughly enjoy working here. And I just want to give everyone a little background about the hospital, mainly because I just want you to see how I see nutrition and babies through our lens, in the sense that we are a very large NICU. So we actually need to change the slide. We're now over 200 beds, and we have a large inborn unit as well as neonatal beds in the cardiac ICU. We have many faculty, practitioners, nurses, and RTs. And I bring this up because as a director of neonatal nutrition, we create guidelines. We have guidelines. We update them every year. And as you can imagine, I'm very fortunate that our large group of providers really follows the nutrition guidelines for the most part. So I'm very thankful for that. But I couldn't do it without a very large group of others that you can see here listed. This is us for Neck Awareness Day recently, our research team. But our nutrition program is made up of a multidisciplinary group of individuals. And these are dietitians who definitely translate research into practice at the bedside. And we're fortunate to have, not all of these work at our main campus, by the way. A couple of these are at some of our other hospitals we have throughout Texas. But I have no disclosures today, and this is my a list of my funding sources. And I am going to talk briefly about human milk fortifiers, bovine and human milk-based fortifiers. And I do want to emphasize they're classified as exempt formulas by the FDA. And here's a statement about that you can see. And today we're going to talk, I'm going to start off talking about mother's own milk and reminding us of differences between mother's own milk and pasteurized donor milk. And I'm also going to compare some different feeding protocols for us to look at today. And I will be referring to mother's own milk for breast milk, but I also appreciate and understand that others may use different terms to identify themselves, but this is what we will be using for the purposes of this talk today. And so just kind of an overview of enteral nutrition. I think, we've come a long way. I was telling someone I need to make a timeline of enteral nutrition. So I promise if you see me talk next, I will have a timeline of where we've come from. But if you think about it, we used to not really feed babies, and we used to be afraid to feed babies because of necrotizing enterocolitis. And fortunately, there have been some enteral nutrition feeding studies that have come out that have given us some guidance on how to safely feed babies and how to optimize enteral nutrition without increasing the risk of NEC. But we want our babies to grow. We know improved growth during the NICU stay is associated with improved long-term outcomes, and we want to avoid growth failure. But we also have this challenge where our preterm babies, especially our VLBW infants, which infants less than 1,500 grams birth weight, we know their intestinal tract is immature. We know they have dysmotility. They don't make the enzymes they need to digest. That's one of the things I'm looking at in my R01 is, we're missing some systems and physiology, GI physiology regarding enteral nutrition. How do we optimize that? Honestly, I'll tell you, the more I learn about my translational research and GI physiology with the intestine, I don't know how we feed babies, but we do it and we do it well. So this is kind of everything we take into account when we're feeding a preterm baby. Now, in regards to necrotizing enterocolitis, we know preterm infants just being born preterm alone are at risk for NEC. as well as if they do not receive breast milk, or if they receive antibiotics. We know that that alters the microbiome composition and can lead to dysbiosis. And all these factors work together to cause inflammation in the gut and what we call a leaky gut and bacterial overgrowth that can cause NAC. And this is a great depiction of NAC from Misty Good's group. And so moving next to human milk, we know human milk is a complex issue. So, we optimize and prioritize the use of human milk. And what's great is I've been so excited over, I've been doing this 16 years now. I'm excited over the last 10 years. There's been a lot of research. There's actually scientists out there studying human milk, which is amazing because we're starting to find out, well, it's not just nutrition. We know that there's immune modulators, enzymes, cytokines, growth factors, and a whole list of other things that we're still learning about. And this is also from Misty Good's group, just showing you some of the immunomodulating components of breast milk. And so this is why I think most recently there is a lot of focus on how do we optimize the use of breast milk in preterm infants and how do we give them that exposure, meaning dose. And I have a slide on that coming up. But just as a reminder, the American Academy of Pediatrics and ESPGHAN, which is the European Nutrition Society, they both recommend that all preterm infants receive human milk and that donor human milk should be used if mother's milk is unavailable. This is mainly focusing on our very low birth weight infants. But this recommendation came out initially in 2012 by the AAP, and then it was updated in 2022. But we know that the use of human milk has its benefits. So lower rates of necrotising, colitis, sepsis, ROP, feeding tolerance. I already told you about improved neurodevelopmental outcomes, etc. We continue to learn about it. And so one of the studies that has come out, so this recommendation actually came out before these studies I'm about to show you. So it was recognized early on that there is a benefit to providing mom's milk supplemented with pasteurized donor human milk. And these are the studies that have shown that. So the first one is the Domino study. And I apologize that I'm going at a quick pace, but I have a lot of slides to show you guys. And I'm happy to answer questions at the end. So there are two studies, the Domino study and the milk study. The Domino study was infants less than 1,500 grams. And the intervention was that if there wasn't enough breast milk, the babies were supplemented, randomized to receive either supplementation with breast milk, or at the time they were doing this study, the standard of care was to supplement with preterm formula. And what they did find was there was no difference in neurodevelopmental outcomes, and they did see a lower incidence of NAC in the donor breast milk group, although this wasn't a study focusing on NAC. The milk trial is from Tara Khaleesi and the network, Neonatal, NICH Neonatal Network. This came out in 2024, but this was less than 1,000 gram babies, as you can see. And what they did is they really targeted babies that didn't have access to mom's milk. So most of these babies were going to receive preterm formula. And so the intervention was to randomize to their standard of care, which is preterm formula, if no mom's milk, or pasteurized donor milk. And again, there was less NAC incidence with the donor milk group compared to formula. And the only other thing I'd like to note that there was some slower weight gain in the donor milk group, and there was minimal breast milk use in either group. So just to kind of keep those studies in mind. But those are two of our recent modern studies. And I just, it's interesting, like when I first started my career, I had this slide in my slide set, and I had taken out for a while, and now it's like, it needs to come back. And the reason why is that I think, and I say this because I do this, my center does this, we forget that mother's milk and breast milk is dose dependent, meaning we want babies to receive as much volume of breast milk as possible. And some of this stems from this paper, for example, was published in 2009 by Minson Deer. And basically, this was looking at NAC or death after 14 days of age. And what they found was that the babies that received increased dosing of mother's own milk had improved survival and less NAC. And over here on the right-hand side, you can see So this is like 100 mLs per kilo per day, and this is postnatal age down here. So just something to remember. I don't think we know the perfect dose still, and I feel like that's something we need to study that we could do. What's the ideal dosage, but this definitely reminds us there's a dose-related effect with the use of breast milk. And so how about innovation? So there is innovation occurring. It's coming to us. We're going to hear more about some newer fortifiers in the future, which I'm really excited about. And so I think we need to continue to be innovators in neonatology to move not just science forward, but care for our babies. And one of these innovations is the MEARS human milk analyzer. I know a lot of centers have this milk analyzer now. We have ours as well. Also, just the concept, and I'll talk about this in a minute, but oral immune therapy or oral care with colostrum and things like that. In addition, there is some innovation trying to isolate particular molecules or parts of breast milk to kind of, give as a supplement or a modular to preterm infants to improve their intestinal health. And so just some of the things that I've found over the years that have been innovated. So one, a donor human milk derived fortifier. So basically taking pasteurized donor milk and making a fortifier out of that. Human milk cream, which I've studied, it's essentially pasteurized donor milk fats, like a concentrated fat component of donor milk. Human milk oligosaccharides, Bo talks a lot about this. So just, these are special sugars that are in the breast milk that interact with intestine directly. And then milk fat globules. It's just so interesting to me. We learn about this like in college and med school, and now it's like really important because these are all kind of appendages that interact with the intestine. And so milk fat globule matters. And I think we're going to hear more about that over the coming years. But just going back to the milk analyzer, the thought of targeted fortification, individual fortification. Should we be reblending donor milk to make sure it's 20 calories per ounce? And I know Dr. Mandy Belfort's doing a study of targeted fortification, and I think she just finished recruitment, she told me. So that's exciting to learn more about that. But this table, while large, serves as a reminder of the differences between maternal breast milk and pasteurized donor human milk. We have to remember that pasteurized donor milk, through processing, it's Holder pasteurization, and it does inactivate some of the immunomodulatory components of milk. And some, of the factors these babies and their intestines need, like lysozyme, lactoferrin. The other thing that I want to bring up too is the digestive enzymes. I don't think we think of this as much. So Holder pasteurization pretty much destroys amylases, proteases, and lipases. And this is important because our really preterm babies aren't making these enzymes on their own initially. They are very immature in that physiology. And so just to remember that depending on also, too, the type of pasteurization, I'd say Holder pasteurization is most commonly used in our milk banks across the U.S. There are some commercial sites that use vat pasteurization. There is one company that uses the retort method. So just to pay attention to which milk bank are you receiving your pasteurized donor milk from, and is there any special processing they do? Especially if you're using commercial donor human milk made by a company versus Hambana Milk Bank. So the other thing to remember, and this is data from our center, Stephen Ford was one of our fellows and is now in South Florida running his own nutrition program. But what we did is we just wanted, this was very early on. I forget what year this was. I thought I had a reference, 2019. But we started this study 3 or 4 years before this, and we just wanted to know, is there a microbial difference between the stool microbiome or intestinal microbiota of babies fed primarily donor milk versus mom's milk over time. And what you can see here, for example, this donor milk is here, mom's milk are the white boxes, and this is over time, weeks 1 through 6. And you can see this is the diversity of the microbiome or the bacteria that are there, and you can see there's more diversity in mom's milk over time, which is what we would expect. So this is intestinal microbiome. So basically babies that receive mother's milk early on, they populate their microbiome sooner than babies fed donor milk. And this doesn't even take into account antibiotics and other things we do to destroy the intestinal microbiome. Another reminder too, this was published from some colleagues. We go to SSPR every year, the Southern Society for Pediatric Research. So it's my shout out to go to some of your local meetings and form relationships with colleagues, because you can come up with cool research questions. But really, this study was just looking at preterm milk versus donor milk. And you can see here, looking at the differences, and there are many different analyses that were done, but one of the examples I'll show you is protein. So this is preterm milk, day 7 and day 28, compared to donor human milk. And the protein, you can see over time, it's quite high early on in preterm milk. And then donor milk is lower in protein. And we know this because most of the moms eat milk. Their babies are older. They're usually in later phases of lactation. And I don't know if their babies are term infants. So it's going to be different. And I'm not saying we shouldn't use it. We just need to be mindful when we're doing our calculations and we're figuring out how to provide optimal nutrition and calories for babies, that we consider the differences between mother's milk and donor milk. I'll tell you, we rolled out the use of donor milk in 2009 at my center. So we've been using it about 16 years. And I do feel like it's sometimes in rounds, we don't even talk about the percent of mom's milk or how many bottles does mom have left in the milk bank versus donor milk. And I think it's just very important to have those conversations, because there are differences and we should be paying attention and helping our moms, paying attention to how much milk we have for mom, and helping moms with their barriers to providing milk if they're able to. And so this is just another slide to remind us of the variations. And so, you know, I talked to you about donor milk's considered term milk. You know, mother's milk can vary over time. And then there's a whole nother layer that I won't get in today, but even just prepping the milk, whether you're using a plastic beaker or a glass beaker, or how you're using, like how you're preparing the milk, where's the fat loss. Even when we deliver it to babies with plastic feeding tubes, breast milk fat gets stuck to that. So I won't go into that today, but that is an area that needs to be explored. That we can think all we want on paper, writing, you know, recipes for babies and giving them all these calories or using a milk analyzer. But if you don't deliver it appropriately to the baby, using the right products, then that's a barrier as well. And so this is, Dr. Brenda Poindexter gave me this slide. I gave a talk with her in January. And so some of these slides are some slides that we gave in our talk. So I love this though, because this is showing donor milk is kind of constant, because we know that it's generally lower in protein and consistently like that. And then we know that preterm milk starts high in protein and then goes down over time. And I think she brings up good points. Should we have a different feeding protocol for babies receiving mostly donor milk? And I know she and Ting Ting Fu have published some data showing how they kind of treated donor milk a little differently than mother's milk regarding feeding protocols. So just something to think about. The other thing I'll challenge you with, and I say this because in this talk that Dr. Poindexter and I gave, I went back through a lot of literature. And what I've noticed is that there's a lot of terminology that's used, and it varies, and it's varied over time. And so sometimes you will see something called, like for instance, an exclusive human milk diet. I would say these days, if you're talking about using a donor human milk-based fortifier, you're talking about that fortifier with a base of mother's milk supplemented with donor milk. But what I will say is sometimes this is what we consider a bovine diet, a bovine fortifier with mother's milk supplement donor milk. Sometimes this is referred to exclusive in older literature because babies aren't getting any formula. So just we just need to pay a little attention when we're not just when we're publishing papers, but also when we're reviewing them and kind of interpreting the data used in our own practice. What exactly diet did they use in this study? And I think it's gotten better over time, but it can be confusing. And so this is an algorithm, a figure that we came up with, Missy Good and Brian and I, looking just at what dilemmas in human milk fortification, and just trying to think through, you know, how all these decision points that you have to make. And what's important is we always want to optimize. We want to have a standardized feeding protocol. We know that having a standardized feeding protocol improves outcomes, even if maybe the protocol isn't exactly, you know, the way we want it to be. We're all doing something, practicing in a similar fashion. The next decision point would be mother's milk versus donor milk. We're going to try everything we can to get mom's milk, but sometimes there's barriers, or mom is receiving chemotherapy, can't provide milk. And so we would go to pasteurized donor milk next. Then which fortifier are you going to give the baby or fortify with? And I'll talk about that in separate slides. And then which feeding volume do you fortify at, and when do you stop? And so these are some considerations. I'm watching my time because I am going fast. So the other thing that to bring up is just the start. And we didn't include this initially in the algorithm I just showed you, but if I had to redo it, I would include it. I think the number one thing you can start with when considering feeding babies is oral immune therapy, which is the new term for oral care with colostrum. Parents love to give their babies, like if they're able to give their babies colostrum, like through the syringes, they feel like that they're doing something for their babies. I have the data here, but the short version is mother's milk supply increases if she is providing colostrum for her babies. And so that is one thing that you can do early on. And so it started with thinking that colostrum is very concentrated, it has special protein and immune factors and cytokines, and so we should be giving it in the buccal mucosa where there is some lymph tissue, and immune factors can kind of work with that. And I think initially some smaller studies showed that it decreased sepsis. There are other studies that looked at other outcomes like ventilator-associated pneumonia, NAC, etc. I will say one of the meta-analyses that I have here of 8 RCTs, there was a decreased incidence of some of the outcomes I'm discussing, but it was really based because one study had the decrease in the outcomes and the other ones didn't really. So it's hard to use that. And then there was another one published more recently that showed, there was decreased time to full feeds, and there may be a benefit on sepsis. Anytime we study NEC, we'd have to have a large power study. So I think it's hard to look at that. But the bottom line is all the studies have found that using moms providing colostrum early on for their babies for oral care have increase in milk supply. And so part of this is just thinking, this is from my friends Aloka Patel and Sarah Taylor, and they published this, but it's a great figure depicting what the intestinal kind of wall or inside of the intestine looks like in a baby fed colostrum versus prolonged not feeding at all. And so even if you're not feeding a baby, meaning feeding tube into the stomach, and you're giving colostrum with oral care, you can see that there's good bifidobacteria here. There's enhancement of the tight junctions so the cells aren't leaky. There's a nice balance here. And then the longer a baby is MPO and not receiving any milk at all, we know that you have leaky tight junctions and leaky cells. There can be bacterial overgrowth, and this can lead to concerns for NEC, but just overall, this is not good for gut health. And so just thinking about that as well and the importance. And I did have a discussion recently with a colleague. We were talking about one of the studies showed that syringes help deliver milk to the cheeks more consistently. So perhaps we should be using that. And that is a burden to have those syringes and have to, if you have a central milk prep room, to prepare those. Swabs can be used. It's just syringes were shown better delivery. So we do have to think about that, but maybe that's something we can incorporate in our care. And just our guidelines here for what we've taken from the literature is that we will, depending on the size of the baby, so 0.5 to 2 mLs per, I think the two, that has to be a typo. I think it must be 1.2. It's not that much. But we put a certain amount in the buccal cavity every 3 hours, basically with care times. And we do use a syringe, and the little babies that maybe are intubated and have very small oral cavities, we may use a swab or just try to kind of put a few drops of milk in the mouth. Otherwise, the volume's way too big for them. But we will give oral immune therapy if a baby's MPO, any size. If they're bigger, they're a term baby and they're ill, or they're a preterm baby. If mom provides us with drops of colostrum early on, we will give that to the baby as oral care. And so that's step one, I would say. So, so doing oral care with colostrum or oral immune therapy. But then step two, the actual enteral feeding part. So I talked to you about earlier, what do you feed the baby? So we already talked about mom's milk and donor milk and the variations there. But moving to enteral feedings, when do you start them? And when do you start trophic feedings, minimal enteral nutrition? These are questions. How fast can you advance enteral feedings and by what volume? And then which fortifier should you use? And when do you fortify? Do you fortify early? Do you fortify late? And I should have another bullet. When do you end fortification or discontinue it in preterm babies? And so what does the evidence show? So again, I could give probably a whole talk just on the literature that kind of contributed to these systematic reviews and meta-analyses. So just know that I'm giving you the summary here. If you are interested, I encourage you to go back to these meta-analyses and the original papers to see what they have to say. But the short version for this is of the large meta-analyses that have been conducted, the first one by Cochrane in 2022, they compared basically feeding before 4 days of age or after 4 days. And so their conclusion was that delaying the introduction of progressive enteral feeds beyond 4 days after birth compared to earlier introduction may not reduce the risk of neck or death in very preterm or VLBW infants. And I think if you've only been in neonatology for 5 years or 10 years, you'd be like, why are you even talking about 4 days as a cutoff before or after? Because I think a lot of us feed a lot earlier now. But that's because when we first, for years, the fear was that if you feed a baby, the baby will get NAC, and we had different products available back then. But there were some studies showing that if you kept a baby NPO for 7 to 10 days, I think it started at 14, then we moved to 10, then we moved to 7. It was supposed to prevent NAC, and then you started feeding after that time point. So actually, looking at the studies that looked at before, after 4 days, is more modern in a sense of where we used to be historically in neonatology. The next systematic review and meta-analysis was published in 2022, and that was in pediatrics. And this was looking at early initiation of feeds, less than 72 hours of life. They found a reduced mortality and shorter hospital stay from the studies that they looked at. And so the literature would support starting trophic feedings before 3 to 4 days after birth, and that's considered early. However, I will show you some newer studies where they started earlier. And so we'll get to that towards the end because it's a slightly different concept. So then how fast can you advance them? So you start them within 3 days of age. And I assume if the baby's, medically feasible, the baby's stable to some point where you feel like you can start feedings. So this is interesting because I think traditionally in neonatology, we've advanced by 10 to 20 mLs per kilo per day if you're doing the ml per kilo type advancements. And there, the SIF trial, I'm just going to point that out. That is one randomized controlled trial that was conducted by Dorling and others. It was published in 2019 in New England Journal of Medicine, but it was a really nice study and one that I feel like has changed enteral nutrition practice in neonatology. So I'm going to talk about that and then the meta-analysis. But it was an RCT and almost 3,000 babies. And you can see the breakdown. They had about 37% of babies less than 1,000 grams. But they found that you could advance feedings at 30 mLs per kilo per day compared to 18 mLs per kilo per day. And that didn't affect your risk of NAC, late onset sepsis, or survival without moderate to severe neurodevelopmental disability. And so I will say this is important. When you read a study, you need to see what were the babies fed? What was the protocol? And it's my understanding from reading the study, most of the infants in this trial were exclusively or partially breastfed or received breast milk. And fortifiers were generally added after full feedings were reached. And so just to keep that in mind, but that I think really made us think, okay, so like for instance, my center, we've always advanced, I don't know, for the last 16 years by 20 per kilo per day. And so 30 is a change, but now, this study supports that. And the meta-analysis supports it as well. This was actually published around the time of the SIF trial, but basically showing that, and it was published by Cochrane, but it showed you could advance feeds faster by even 30 to 40 milliliters per kilogram without, they didn't see any adverse effects. And so I have 30 here highlighted in yellow because that is what the current literature supports. I will say we have increased our protocols on our higher birth weight babies to advance by 30 mLs per kilo per day. Still working on the smaller babies or, the less than 1,000 gram babies. Not that I don't believe the literature, more that it's a big practice change for us. And so we will get there, but a lot of places are using advancements of 30 milliliters per kilogram per day now, but a lot of those centers are using mother's own milk supplemented with donor human milk. So to continue this concept, kind of what I talked earlier, how fast can you advance, and could you, I think generally I showed you where it said you should start feedings within 72 hours. But the question is the low volume feeds or the trophic feedings. Should you do that for 1 day? Should you do that for 3 days? I think traditionally we've done 3 days. And so this study came out from Ariel Salas's group, and it was a great study showing basically they randomized, these are slightly bigger babies. And when I say bigger, more on the like above 1,000 gram birth weight range. And what it showed though is that you could advance feeds after 24 hours. So meaning baby's 24 hours old, you start trophics, and then after that, you can keep advancing. And so these babies got to full feeds rather quickly, and because they did not do 3 days of the traditional trophic feedings. And so this study is being repeated in a multi-center fashion, large numbers, and Greg Valentine and Ariel Salas is doing this in something called the Let Feed trial. So our center is part of that study, and we're just starting, but that'll help answer that question in a multi-center setting. But I would say majority of centers start trophic feedings once babies are medically stable, meaning generally they're not 100% oxygen, they're not on pressors, etc. But I will say there are some centers that still prefer to wait until mother's own milk is available, meaning they may not start donor milk right away. And there's, I've heard of a couple studies that are going to be done looking at that interval. Should we just wait to give feeds until we have mom's milk, or should we be giving donor milk early? Because that hasn't been well studied in the literature. And then to take it a step further, this concept of early total enteral feeding. And so this is basically babies, the thought of this strategy is that babies would receive their fluid volume requirements in the form of enteral feeds. They would not receive supplemental IV fluids or TPN. And some of these studies, like Dr. Nanjia's study, which is the second one, and they call it ETAF. It was a randomized controlled trial in India looking at ETAF, and it was 1,000 grams to 1,499 gram babies. And basically these babies got to full feed sooner, and they were able to leave the hospital sooner. And then there was a study conducted by Ariel Salas's group looking at a similar advancement. So infants either initially received, within the first 36 hours after being born, they'd receive 60 to 80 milliliters per kilogram per day of enteral nutrition compared to trophic feeds around 20 to 30. So I think this is great. I think it needs to be studied more. I think I just have done neonatology at this point long enough to see all the different ways, and we used to be extremely conservative. So it is good to see some studies looking at some more kind of quicker approaches to feeding, but I think we're going to hear more about this in the literature to come. And so this is just an example of the Texas Children's Baylor College of Medicine feeding protocols. And I'm just showing these, for example. I have another slide next of some other feeding protocols from other centers. We do a weight-based feeding schedule. That's how we've always done it. That's what makes sense. And I will say, to be fair, a lot of the literature is weight-based. I was at a nutrition conference with colleagues recently, and we were having a discussion. Maybe it should be gestational age based on developmental physiology of the intestine. But that's going to be a little tricky because a lot of these studies were done on birth weight. So more to come on that. But basically, depending on where you are in the birth weight range, This is where you start volume of initiation, and you can see we're still at 20. But for our kind of our babies 1250 or above, we will advance by 30 per kilo per day of enteral feedings after trophics. So that's one example. And that this does not include 22 or 23 weekers. And I could give a whole separate talk on nutrition for that population. And then these these are from Aloka Patel and Sarah Taylor. They are two hospitals. And just kind of going through and looking at the similarities and differences, they both provide, just like my center does, oral care with colostrum or oral immune therapy early on. So 0.2 mLs to each side, or 0.1 to each side of the buccal mucosa. And that's more what we do. So I need to fix that typo on that other slide. But then feeding, they try, I know Rush focuses on using mother's own milk for the first feeds if possible. And then New Haven or Sarah's group has kind of some more definition around why you maybe wouldn't feed a baby. And that makes sense if you're on higher doses of dopamine or epinephrine. And then talks about donor milk. And then here's their feeding protocols. So we're an ml per kilo per day institution, but for both of these protocols, they're done in milliliter, like 1 ml for 4 days, 2 ml for 3, depending on the different weight criteria. So just to kind of show you that. And I know the talk will be available afterwards, so you can take a closer look at these. But they're, I would say, similar, different, but similar. And then let's see, this is from Fernando Moya. He took the algorithm I showed you guys earlier and kind of made it look a little different. I like his version, but we'll keep going to these decision types. So I think I've told you what to feed with, when to start, how, or at least what the literature shows, how to advance by which volume. And then what about fortification? And I'm watching my time because I want to give time for questions. But I would say it, especially in the United States, majority of nutrition experts will tell you that we have to fortify feeds, especially for babies less than 1,500 grams birth weight. That's where the evidence is the strongest. And by fortify, that means adding extra protein, calcium, and phosphorus, as well as calories. And I think a lot of us focus on the calcium and phosphorus. These babies are born early. They don't get the transfer minerals from the placenta, and they need extra calcium and phosphorus. And that cannot be provided by high volume breast milk. So I have some colleagues in the UK that don't fortify, and they say, well, you can give 220 milliliters per kilogram of plain milk. The problem with that is you might meet your energy needs, but you're not going to meet your calcium and phosphorus needs. And we worry about, because I've seen broken bones from poor calcium and phosphorus supplementation, seen early rickets and things like that. So I would say most of us fortify. I will say, though, definitely we need more studies in this area. We know that at least the data that we have shows that in the NICU, they have better weight gain and linear growth. And we know that those are associated with better neurodevelopmental outcomes. However, the studies that have currently been conducted with long-term follow-up of babies fortified doesn't really show a neurodevelopmental difference. But I will take in-hospital weight gain and length gain. I think that's a very important outcome. So I could give a whole talk on fortifiers, and I'm not going to be able to today, but just to kind of go through the different fortifiers real quick. So this is a list of all the bovine milk-based fortifiers available in the U.S. I will tell you the Similac powdered HMF, they have transitioned that out. So I don't believe it's available, or if it is, it's being phased out. Everything's liquid now. And you can see the different types of liquid fortifiers that are bovine based, but just to show you the protein ranges. And again, it matters if you use preterm human milk protein for your calculations, you're going to give more protein than if you use mature term milk, which is less in protein. So when you add the fortifier, you're ultimately going to get less. And then I just mentioned iron because depending on which brand of fortifier, you're giving iron or you're not. So you need to know that so you can supplement adequately. And then last but not least, the displacement of human milk. And so when we add fortification, especially with liquid products, that is going to take the place of breast milk. And so I showed you that breast milk outcomes are related to dose response of breast milk. So we want to provide as much milk as possible. And so I will tell you that we do need newer studies. There's not a lot of new studies looking at the current types and brands, not of all the brands of fortifiers that we're using that are bovine based. And then we still have questions. I mean, is an extensively hydrolyzed bovine fortifier more favorable than a partially hydrolyzed one, or is intact protein fine? Powdered bovine HMF displaces the least amount of mom's milk, but most of us have moved away from using powder in the NICU. And so, but the problem is liquid bovine fortifier displaces more milk. So those are some considerations. In regards to the human milk-based fortifiers, there's one company that makes it. And you can see, I would say most centers that use a donor milk-derived fortifier start at 26 calories per ounce, because the +4 or 24 calorie fortifier will not provide enough protein and ultimately won't get you to where you need to be to grow the infant. But as you can see here, the displacement of mom's milk is at least at the 26 calorie formulation is higher. And if you go up even more to 28 calorie, 30 calorie donor milk derived fortifier displaces 50% of mom's milk. So something to keep in mind. And so, for instance, my center uses this product, and what we do is we optimize protein first, and we add some donor milk cream or donor milk fat before going up on the protein again. So trying to kind of even out the calories so we don't have to displace as much mom's milk. What I will tell you is I usually go through all the studies of a donor milk derived fortifier that have been conducted. For today, I'm giving you the abbreviated version, and there was a meta-analysis recently published in Nutrients in 2024, and it included 3 randomized controlled trials, the ones we usually talk about, the Optimum study in O'Connor, the recent Jensen study from Europe, and then I say Lucas 2020 with a star because it's the original Sullivan study that studied the donor milk derived fortifier. They took all the babies that received mom's milk with bovine based fortifier and put them in this kind of meta-analysis. So meaning none of these babies in this meta-analysis should have received formula, if I'm understanding the design correctly of the meta-analysis. And so you can review this. These are the studies that they included. The Assad study was retrospective. All the others were RCTs, and while they were great in their design, they're small. They're small in sample size. A lot of them talk about NEC. None of them were powered for NEC. And actually, the Jensen study, which a lot of people were waiting for it to come out, they actually stopped the study early. So they found no difference in outcomes, but they stopped it early because one of their main outcomes was sepsis. And they had such a low rate of sepsis that they were going to have to study 1,000 babies to finish their trial. So what this meta-analysis did show, they looked at primary and secondary outcomes, and they did find a decrease in mortality in the human milk-derived HMF group. And as I mentioned, this included 2 RCTs and then a subgroup analysis of one of the RCTs for the mortality outcome. And this is kind of, when you're looking at the forest plot, looking at meta-analyses, there are a couple of things you want to look at. One, I mean, this does nicely sit over here, the overall for mortality, looking at these studies, this is positive for the human milk-derived fortifier, but a lot of these outcomes, you don't want these lines crossing one, and they do. The other thing is, as I mentioned, for this Sullivan study that's mentioned here, this is only the babies that received bovine fortifier, not formula. So it's kind of hard when you're taking RCTs, but you're only taking part of the babies randomized in a study and putting that into a meta-analysis. So I still, while I appreciate looking at the data in a different way and putting this meta-analysis together, it still doesn't answer our question if you're looking to see if a human milk fortifier decreases NEC, because that study will take 1,000 babies and no one's conducted it. So just to kind of fill you in on that. And so, for instance, the Koletsko nutrition book, and I got this from Dr. Poindexter, the conclusions that there's no evidence to justify recommending a preferential use of human milk-based fortifiers over bovine milk-based fortifiers. And they're also acknowledging that the cost of the human milk-based fortifiers is more expensive. But what I will tell you is 40% of level 4 NICUs, based on a recent survey, are using the human milk-based fortifiers, including my group, and we've been using them since 2009 when we introduced pasteurized donor milk. And I will say there are some smaller studies, some of them I've published looking at translational research, meaning looking at more of the basic science and sciencey parts of the differences in fortifiers. And there's some kind of signals that perhaps human milk-based fortifiers in some translational aspects and science-wise may have a benefit, but that's still, not been shown in any large randomized control trials. Also, I think it depends on your unit. My unit, despite having the best lactation team and support possible, we still have like 30% of babies that still get primarily donor milk. And what do you do with that population? Because, for instance, the O'Connor study, that was one of the randomized studies looking at the fortifiers, they had such a high breastfeeding rate. Same with the recent Jensen study. That population got 3% donor milk. My unit's more like, 30% donor milk, despite us trying really hard. So I think it's hard to assess some of these studies. And also, all centers have different NEC rates. And some centers have introduced a bundle which included the human milk-based fortifier for NEC, and they followed their outcomes. So I still think we need a very large study, and that's what I will say for that. Again, could give an entire talk on that. But moving on, so you've chosen your fortifier. When do you fortify? And I think in the past, most people would say full feeds, and past meaning 10 years ago, I think we'd say full feeds or 100 milliliters per kilogram per day. My centers moved down to 80 per kilo per day with the use of bovine fortifier, or 60 per kilo with human milk-derived fortifier. And you can see here, this table shows different ranges. And then I came across this and I was like, whoa, I hadn't, this is recent, that I'm going to show you two studies fortifying very early on. So this is by Errol Salas's group in 2023. But this was basically looking at 150 extremely preterm infants. And one group received a human milk-based fortifier to 24 calories on feeding day 2 until 2 weeks of age. And then they were switched to a bovine. That was the intervention. The control group was bovine fortifier being added at 2 weeks of age. They saw no differences in outcomes, but they did see some positive indicators on body composition in the babies that received early fortification. So this is fortifying very early with a human milk-based fortifier. And then on the flip side, this is an RCT of early fortification with a bovine-derived fortifier from Augusta, Brian Stansfield, and the author here was Winter et al. But this was published recently, and smaller study, but they still randomized babies to receive milk fortified with bovine fortifier to 20 calories per ounce until 10 days, and they switched to 24 calories. On the control group was their standard of care, where they added bovine fortifier at 80 per kilo. They saw no negative outcomes, no differences in NEC, and they didn't really see a difference in growth. So I don't know where I fall with early fortification, but it's good to know that there are some papers out there showing that you can do it early. So maybe we all should kind of move our bar a little earlier, but more studies to come on that. And then for discontinuation, I'm going to go through this quickly because I want to save time for questions. But the bottom line is there's not a lot of great evidence. There's some guidance, expert guidance from ESPGHAN and our European colleagues and their nutrition group. It also depends on how the baby's orally feeding, how young the baby was born, what's the mother's breastfeeding plan when she goes home. So it sounds like 34 to 36 weeks, or the ESPGHAN uses 1.8 to 2 kilos as well to start transitioning off fortifier. But I think if a baby is clearly going to be in the hospital another month and they're 34 weeks, you have tons of mother's milk, I think it's fine to continue human milk fortifiers, meaning bovine generally the human milk-based fortifiers are transitioned off at 34 weeks postmenstrual age, and that's because that's what the studies have all done. Also, that's when neck risk really starts to lessen. So that I would say 34 weeks for human milk-derived fortifier, and then bovine milk-derived fortifier, it just depends on when the baby's going home, I think. And so I am out of time, but I did want to say some of the reasons that I kind of transitioned a little. I still do clinical research, but some translational research is that I did an RCT looking at 2 different protein amounts, and there wasn't a big difference between the groups. I was really frustrated because I was like, surely this is going to answer one of our questions. And it made me think, what else are we missing? Like, I know there are genetic reasons why babies don't grow and, outcomes are different, but there's other physiology we're missing. And this is kind of how I went down the dive into looking at fatty acid absorption in relationship to the liver-gut microbiome axis. And I have a great group of collaborators, including Cami Martin, who's helping me. Her lab is running the fatty acids that we're collecting. But the short version is the microbes that you have, that preterm babies, and we have prelim data to prove this. Preterm babies, depending on which microbes you have there's certain microbes that make enzymes, specifically in my case that I'm studying, bile salt hydrolase enzymes. And these signal to the liver, and they also convert primary to secondary bile acids. And bile acids are very important for emulsification of fats and therefore fatty acid absorption. And so if you don't have the correct microbes there, you're not going to have bile salt hydrolase, and this whole process is not working the way it should be. And so we're doing an observational longitudinal study trying to figure out that we know there's some developmental changes. So meaning older gestational age babies and older postmenstrual age babies, like they eventually will get this whole circle or process working, but early on, it's not there in some babies. And so that's why sometimes I'm like, how are we even feeding this baby? How is this baby growing on full feed? So clearly it's a very complex process, but this will at least allow us to answer some questions and hopefully have more questions to continue further studies. But just to tell you about the future of enteral nutrition, I will say, hang on. I feel really good that there's some newer generation fortifiers coming based on discussions I've had with some companies. There may be some alternatives to what we're currently using. I also, there are some companies working on turning mom's milk into a fortifier, and that would be very promising. So I think number one, we need better strategies to help with lactation and milk production for moms of preterm infants. We need to continue to work on that, but these newer generation fortifiers are coming. And I just say, like, wouldn't it be great to have a product that kind of provided the protein and nutrient goals you wanted, but didn't displace a ton of mom's milk, or, et cetera. So then kind of, again, future therapies regarding GI physiology in relationship to enzymes and fatty acid absorption. And so this is Liam. He was one of the first babies and one of the studies I did, and I got to follow him to 5 years of age. And it's just so great to see our babies doing well, but we have to keep moving the bar. This is a shout out for the Next Society. I'm on their advisory committee. We do have a conference coming up in Chicago in September. It's a great conference. So if you're interested in attending, check it out. Couldn't do this without my funding sources and my team, as well as the support from my section chief, Dr. Chris Reber, and my colleagues. And then here's a plug for our nutrition conference we host every year. It's virtual, and we have a great lineup of speakers we're getting together this year. Some controversial topics in neonatal nutrition. And then this is the QR code for some of our guidelines that I talked about today here at Baylor College of Medicine, Texas Children's. So with that whirlwind, I will take any questions.
That was awesome, Amy. I'm going to ask you for a favor. Can you go back to that QR code?
Oh, absolutely.
I'll take a little pic of it so that I can send it around. So that's so incredible. I know that Baylor does this every year where they allow people to download and see their guide.
Yes, awesome. They are free, and we work very hard. I mean, I'm talking very hard to update them every year. So
I believe it. I know it. So on that, I wondered if there was a feeding protocol or guideline from Baylor about taking into account the donor milk versus mom's own milk. Is that yes?
yeah, no, I'm nodding my head like that's a great idea.
Yeah.
Not yet. How about
Not
that?
yet. Okay.
Because we have such a large dietitian team, we have 7 dietitians. I mean, we have 200 babies, but we try to keep that in mind. But I think that would be beneficial in the sense of just trying to recognize some strategies. One thing we are working on is we're trying to really pay attention to displacement of mom's milk with fortification. So we're trying, like, for instance, we use a human milk-based fortifier. And what we try to do is we'll add the donor milk fat before pushing the protein. Like, we get to protein of 4 per kilo, add donor milk fat, and wait. Because otherwise, if we go up on protein, we're going to displace more mom's milk. And so, but donor milk, we are fortunate. Our Himbana Milk Bank provides pooled donor milk that is 1.2 grams per deciliter of protein, which is a little bit higher than normal. And so we give that to our tiniest babies. So your milk bank may have that option as well. So you're starting with a higher protein, because it used to be 0.8, right? And we all use 0.8, and then it was 1. And so some of the milk banks have milk analyzers, and they're able to pull the milk and give you like almost like a preemie product. So that's another idea.
Oh, that's so helpful. You're right about asking more questions than answering after hearing this, with all the donor milk and the fortification and the human milk. One of the things I also wanted to ask was about the Let Milk study, the from Solace. Did you mention, or do you know what's going to be the lower range or the lower limit of gestational age and or birth
Yeah,
weight?
no, that's a great question. So the Let Feed trial that's multi-center, I think it's 23 weeks is the lower age of gestation, but I'd have to look at that, and maybe 24. I will tell you that at our center, where the actual intervention group where you're feeding faster, we're already doing that in a good portion of our population. So we're only able to recruit some of the smaller babies. I do believe in the study. I think it's a great design. I do. It will be important to include some smaller babies, because I think those are the ones we're worried about. Just being able to tolerate feeds in general, even regardless of how fast or what volume,
And you had mentioned that, like, feeding the micro preemies, right? The 22 to 24 weekers, or 22 and 23. Is there a separate protocol where you're at for feeding those kids? And can you give us some?
Yes. Yeah, I almost had a slide, but then I was like, I have too many slides. No, we do have it. It's in and if you go here, it's actually in our it's called peri-viable guidelines, and it includes the feeding. So it's not in the nutrition chapter, but the advancement, I have a slide showing. So if you have a 500-gram baby and you follow the protocol we're using, it takes about 18 days for babies to get to full feeds, full fortified feedings. And our internal data that we're working on publishing shows that 22 to 23 weekers, most of them don't reach full feeds until about 30 days, and that's the median. So the reason I bring that up is I feel like as a neonatologist, or at least my group, if we can't feed a baby, it just feels like we're not doing something. And so I wanted to look at our data to say, hang on, just try to give the baby a little milk. It's not realistic to expect a 22 or 23 weeker to be able to get to feedings before a month of age. And John Klein, I had a discussion with him from Iowa. He said it's similar at his institution. So it'll be nice to get some of that published data. But I mean, I think we start at 1 ml Q6, which was a huge change because we do Q3-hour bolus feedings, and we're very strict on that. But the 1 ml Q6, and after a certain number of days, we go to 1 ml Q3. And so, and I will say we got that from the Tiny Baby Collaborative. So it's not, it is in our guidelines, but we didn't necessarily create it all. So I will tell you that. But I will tell you 1 ml Q6 is usually the nurses are okay with that because it's a tiny amount. So like, I don't know. It's like, well, I want to feed the baby. Well, I don't want to. And then it's like, how about 1 ml Q6? And then, everyone feels comfortable with that. So
yeah, bit of a negotiation.
Yes.
So many things are. We've got a nice question here about, if the general recommendation is to stop fortification at 34 to 36 weeks or so,
Right.
is there a tracking system to monitor catch-up growth post-discharge, and what might that be?
Yeah, that's a great question. And I apologize. I need to fix those slides and what I say a little. I meant coming off the fortifier. It would have been helpful if I also added, so you will switch to something, some type of supplement. So generally, let's say a baby's 34 weeks, they're going home, we think they'll go home in 3 weeks. We will come off the fortifier and then we will add their discharge diet. So generally for us, if a mom wants to breastfeed, that is 6 breastfeeds a day and then 2 full bottle feeds of a NeoSure Emphycare 22 calorie per ounce. So we still give supplemental calories, protein, calcium, and phos. We just don't do it in the sense of a fortifier. I do know some places send babies home with fortifiers. We just haven't been able to kind of logistically work that out here because we have such a large catchment area. But I know some people send babies home with fortifier. And then some centers, I know in California, I've heard that you guys are able to get SSC 30. That's the Preemie Similac formula. And so I would like to switch to that. I just need to work on the logistics. So you could do 2 feeds of SSC 30. So I think it just depends when they're going home. So I apologize. I wasn't suggesting don't fortify them at all. I meant like switch them to their home diet with a little fortification. But yeah, I mean, you should follow their growth. I mean, some babies are not growing and then you don't want to give them less calories. So you can keep them on fortifier until, a week before they go home. Or I think our policy is like 3 to 4 days before they go home, we want them to be on their discharge diet just to make sure they're tolerating it. But that, yeah, I need to talk a little bit more about that section. It's a little tricky.
Yeah, that's really reassuring. One of the really lucky things we have here in the Permanente system is that we have fantastic follow-up. It's just, to me, it's super remarkable coming from, like you said, a large catchment area. I came from Oklahoma and academics, and it would be nearly impossible to follow up all those kids like that and manage the fortification. Before we end today, if you have like 1 or 2 take-home messages or things that you really want us to focus on, could you leave us with those thoughts?
Yeah, absolutely. I would say, yeah. So one, I would say bring the discussion of mother's milk or, the breast milk into your daily rounds. Like we just say, oh, baby's on breast milk or donor milk at 150 with fortifier. Like really try to pay attention to like, are we helping this mom produce milk and how much, like we should not be wanting to use a lot of supplemental donor milk. So focusing on mom's milk. And then I think the oral care with colostrum or oral immune therapy, I know a lot of places are doing that, but not everyone is. And our nurses have really championed that. And like I said, the parents love it. Parents don't want to stop it. We let them keep doing it. We're not, because it's something they can do for their baby. And we have shown it increases mother's milk supply. So I guess those are 2 things. And then third, I would say, look at your guidelines. I know you guys are a little bit more organized in California. I feel like you have a lot more centralized guidelines. But I mean, I always, based on all this literature, just you always can tweak things a little. So those are 3 points, not 2, but
I'll take them. I'll take 3. Thank you so much. Yeah, this is awesome. So the colostrum and oral care, making sure we are very cognizant at the very least of the donor milk versus the mother's own milk and the fortification process. So anyway, thank you so much.
Thank you.
I can tell that you love this subject just by the way that you know so much about it in all these separate studies. So we really, really appreciate it. This is such an important thing. I think we might need to have you back to talk about fatty acids and all of the R01 because
that's a separate talk. Yeah, for sure. I could talk you through research, but thank you so much for having me. And I'm always happy to answer questions too, like later down the road. So feel free to reach out. I may take a little bit to email back, but I'll get you. So.
Really appreciate it. I think the next one will also be intestinal rehab.
Oh yes, that too. That's another love of mine. And intestinal rehab in the preterm infant. That's a great one.
We have big questions on that. So thank you everybody for joining. We'll see you next month in July. We're going to be talking about chronic phase invasive and non-invasive ventilation in severe VPD with Dr. Ram. Have a great day.
Okay, thank you. Bye.
Thanks, Bye.
Thank you.